I'm here now. Well, good afternoon, everyone, and thanks for tuning in, whether you're here on the Zoom call or on the YouTube live link or watching us asynchronously at some time in the future. My name is Dr. Eric Kennedy, and I'm an assistant professor of disaster and emergency management at York University in Toronto, Canada. And this is part of the COVID-19 Survey Methods Working Group, where we're learning about different survey and questionnaire research occurring on the topic of COVID-19, and in particular, diving into the methodological challenges and lessons learned from this process. As always, we have a guest speaker with us today to discuss some of their experiences in doing COVID-19 survey research. They'll give a short presentation, and then we'll have a chance for any Q&A based on the conversation that we're having there. If you're on Zoom, you can feel free to share your comments in the chat box and questions that you might have. And if you're on YouTube, you can use the chat function there, and I'll be able to ask the questions in real time as well. With that, I think I'll pass this over to our guest speaker, Dr. Parasa, who joins us from Washington State in the United States, and is a physician and practitioner doctor who has worked both in the front lines in the medical field, but also in conducting survey research. And I'll leave it to you to introduce a bit more about your project, but we're looking forward to the conversation and to broadening these questions of surveys to expert audiences as well. So thanks so much for joining us today.
Thanks, Eric. Thanks for the invitation. In terms of what I do, I'm a gastroenterologist. Basically, we deal with the gut, and that's my day-to-day clinical practice. And I'm based in Seattle. So one of the first case in the United States was actually diagnosed in the neighborhoods of Seattle. So we did have some first-line exposure in terms of how things started or unfolded in March 2020. And, over a period of time, we are 1 year out now. So things seem to be doing okay here. But in terms of the research, I mean, apart from the clinical research, which just involved understanding more about how COVID-19 affects, different organs in our body, this particular study, which we have done, was more to kind of get an insight into how COVID-19 actually had an impact on endoscopy. Now, for those of you who are not in the medical field, endoscopy is basically a procedure where we have a tube with a camera at its end, and we go through the natural orifices, which could be your oral cavity or your rectum, to kind of understand what's going on in your GI tract. In special cases, we also go to the ducts of the pancreas and liver and so forth, depending on what the underlying condition is supposed to treat. So on an average, there are about 2 to 3 million endoscopies performed in the United States in a year. Because colon cancer is the third most common cause of death in the United States, colonoscopy is one of the gold standards for prevention as well as detection of colon cancer. So if you do hear that jargon, I just want to give you a background as to why this study we felt was important, because colonoscopy is a screening modality apart from just doing therapeutics, in the sense, let's say we have a patient who comes in with GI bleeding, to the emergency room, we have to go in with a scope and try to control the bleeding. If you have inflammation of your gallbladder, which is the little pouch next to your liver, and if the duct gets blocked, we go in with a duodenoscope, a special kind of scope, and go clear the duct and prevent infection and so forth. So those are some of the more, what we call therapeutic things that we have to do during emergencies. And also on an elective basis are the screening modalities. And endoscopy is also the primary modality for screening precancerous lesions in your GI tract, for esophageal, which is your food pipe cancer, your stomach cancer, colon cancer, and so forth. Now, laying that background, let's see. Okay, so those are my disclosures. And basically, I think this is the most important slide for this particular presentation. So we've done what we call the global survey of the impact of COVID-19 on endoscopy.
And
Mhm.
sorry to interrupt, but we're just not seeing the slides yet. So I want to make sure that those are pulled up there.
Share your screen, Sravanthi.
It is share screen. Can you see that?
Nope.
Interesting. Hold on. Give me 1 second. How about now?
Good. Yeah.
Okay, that's better. Okay, so
thanks so much.
No problem. Basically, so we've done the global survey of the impact of COVID-19 on endoscopy. And the way we've done that, it was a very simple study. We didn't have a lot of survey questions. It was only a basic of 16 questions. As you can see from the slide, the survey was sent April 23rd, 2020. And we just gave it a 1-month turnaround for our survey participants to complete the survey, because we were trying to capture the acute impact of COVID-19 globally, which was at this time period was about the same time period that we saw a huge increase in cases in New York, in the United States. Italy was bombarded, and as with many other countries in the world. So we didn't anticipate that the pandemic would take so long, but we just wanted to kind of get a sense as to where we stand in terms of the number of procedures that were done globally and what kind of procedures were done, and also to know if the healthcare providers who are involved in doing these procedures, which is just not the physician, but also our nurses and technicians, if they did have exposure to COVID-19 while doing these procedures. And also one of the important thing that we wanted to learn was, did the physicians and the healthcare workers have adequate personal protection equipment, or PPE, at that time? One of the reason this survey was kind of timely at that time was globally, most endoscopy, and I was involved in the network of the international working group, is the recommendation was to stop all elective procedures, all non-emergent diagnostic procedures, unless it's a medical emergency. All the procedures had to be halted so that we have adequate reserves, both in terms of PPE as well as hospital beds available for patients who might be getting admitted for COVID. So all non-emergent services were shut down globally. And that was the reason for, the context of the introduction to this kind of study as well. So basically the 16 questions where we collected information on where these, who is doing the survey, right? In the sense, where are they located, which city, which country, which continent, kind of thing. And what is the baseline volume of these procedures that they do on a regular basis? This was important for us to understand because tertiary centers, meaning a big hospital, might be doing more volume at baseline and might be continuing to do more volume or less, we don't know, as opposed to smaller centers or ambulatory surgical centers, which probably have completely shut down during that time wave. The other thing we also evaluated is, did they have any shortage of personal protection equipment, and were they using any specific kind of personal protective equipment, and did they have shortages of those? Because as our procedures, some of our procedures involve very close contact with the patient and aerosolization of their body contents, which can put us at risk, the endoscopists and the people involved in the room, for higher risk for infections and so forth. So we need special N95 masks for all our upper endoscopies and so forth. So that was basically the goal of the study. And the way we deployed that is by a simple red cap survey methodology. We just created an easy link. And it was deployed through what we call a World Endoscopy Organization. We are a centralized organization where gastroenterologists across the globe are members of. and participate in regular, guidance or, any kind of issues that come up. So typically the WEO provides guidance for management of a certain disease, or what you should do for complications and so forth. So that's the guidance authority. And as part of the WEO, of which, the task force of which I was part of, we decided to deploy through them. So what happened was, once we created this short survey and got the institutional review board approval locally, the good thing about COVID also was these kind of things got approved faster, because everybody knew that it's an emergent situation, and any kind of COVID research got a priority over other existing things in terms of getting the institutional review board cleared. So once that was done, we just had a neat link from REDCap, and we send it to the WEO secretariat, and they basically put that in their mail list. So that goes to all these, I think there are about 16,000 endoscopists across the world. And then they send it out to those different centers. And the individuals in our case was not an individual's physician, but it was a unit, meaning a hospital in itself. So each hospital could have multiple physicians and technicians and so forth. That was the method we basically used for this portion of that this kind of survey is being done, and for gastroenterologists to participate in this kind of survey. And then we wanted a quick turnaround, because we wanted to everybody to know what is going on everywhere else in the middle of the pandemic, or even in the early stage of the pandemic, looking back. And then use this information to provide further guidance or further research steps that need to be taken to kind of work on a longer term to understand what's going on within our medical community itself. So that's just the overview. And then as I discussed in previously, the volume of endoscopies that were performed basically were to conserve the resources that we have and PPE. And a lot of times, patients don't want to come in the middle of the pandemic for a screening procedure, right? That's not the priority. So these are some of the things that we did consider when we were designing the survey. Now, this is just a Arcgis map of the different centers globally that participated in this survey. And each spot, the bubble is not site specific, but we just know that different spots indicate different centers throughout the world. So apart from Russia and USSR, for lack of a better word, we had participation from across the globe. And I'm not going to bore you with these details, but just so that you know, there were a total of 255 centers across the globe that participated. And depending on we kind of stratified the results by the continents. So you have different continents. And for New Zealand and Australia, we just combined it as Oceania. And on an average, there were about 8,000 procedures being performed in a center in a year. And totally, it would indicate, 206,000, 269,000 procedures in a year. So almost like 2 million procedures in a year. These centers that participated basically contributed to that. And these are the rest of the demo, split in terms of the number of endoscopists in each unit and technicians. And the other thing we also asked was if any of their endoscopy staff, meaning the people working in the unit, did have COVID infection during that time period. And 13.5% of the centers did say that they had at least one person in their unit get COVID-19. Now, whether this infection was contracted during procedures or, just, health risk from occupation versus was it something that they acquired from community is really hard to kind of say, but that's what we know. And then again, this one is just to give you a sense of the scale at which these procedures drop. Most endoscopy procedures, other than Oceania, which is New Zealand and Australia, you guys did a great job. Every continent had a decrease in the number of the proportion of procedures that were done, but most of them looked around 10 to 15% of what they would do at baseline is what they were performing at. I'm assuming all of them were mostly emergencies or really high-risk patients who cannot wait until the acute pandemic we are done with. But New Zealand and Australia seem to have relatively less impact in terms of what was going on in their day-to-day life. So we didn't see a significant drop. It was only 30% from baseline. And this is just a different kind of stratification depending based on the type of procedures that's more specific to us gastroenterologists, but also based on the volume of procedures that were done at baseline in different hospitals. So we also did focus on N95 use because that was a prized commodity during the peak of pandemic. And the upper endoscopy is the one that we usually worry about aerosolization, and that was kind of recommended as a must to wear when we are doing these procedures. And as you can see, there is a significant, you would want all these numbers to be 100% ideally, but you don't see that in reality. So that was the gap that we are trying to address as well. This was based on the volumes. We then thought, hey, maybe it's not the plan part of the world that you are in. Maybe it is the total sheer volume of procedures that you're doing. And because you're doing more procedures, you probably don't have access to as much PPE versus maybe you do have because of donations or the hospital is acquiring it quickly. But it really didn't matter depending on the volume of procedures performed at baseline. I think that's all I have from my presentation. And let me quickly show you. This is basically the survey that we sent through REDCap. As you can see, it's a fairly short survey. We physicians have a very short attention span. And if it's anything beyond 15 questions, or if it takes more than 2 minutes to fill this, it's really hard to get participation. So we tried to choose the questions which we thought were important to be addressed at the height of the pandemic, which would give us more information as to which direction we have to go. So I would stop there, and I'm happy to take any questions or discussion points.
Absolutely. Well, thank you so much. That was a fantastic overview. And I think a really interesting window into a world that I don't think about very often, but reveals a different side of survey methodologies and just a different side of COVID from some of what we've talked about as well. And I know I've got lots of questions, but for anyone on the Zoom call or watching on YouTube, feel free to use the chat box to pose any questions that you might have for the conversation over the next 25 minutes or so. Okay, so I've got a lot I want to ask about here, but I'm curious to start a little by just getting a sense of the respondents. And I mean this in a broad sense, because you've laid out a project that covered 55 countries and several hundred units. And I assume that there's a lot of variation from unit to unit. You mentioned the size of these. right, the tertiary care hospitals and major trauma centers through much more rural or small scale units. Presumably these have very different administrative structures and perhaps even different cultural norms around when endoscopies are used and how often they're recommended. I'm wondering if you can give us a sense of some of that diversity and how it entered into the responses that you got, but also the survey design that you used when speaking to such a diverse group.
To answer your question, that's pretty much our results in the terms of diversity of the different participants and the different endoscopy units. So the way we kind of try to tackle or throw more light on it is, for us, it's the absolute volume, right? Is it what is it that you're doing at baseline? Let's say there was no COVID. How many procedures were you doing in the last 1 year on an average? That's what we tried to find out. And then the next question was, what is the percentage of that baseline are you doing right now in the last 1 month when we started seeing this pandemic? So those were two questions that we kind of addressed. And for most part, there is a small variation in the number of endoscopies that are done at baseline. And that did vary based on the continent and different centers that participated. So at the end, what we were looking was, are we capturing maybe representative groups of all these different ways you can slice and dice the data, basically, right? It could be by continent, it could be by geographic location, and the size of the endoscopy units. Was it a tertiary hospital versus is it ASC or a small center? So again, to keep it as to keep it very focused and not to go berserk on like having 50 questions to answer that. That was very important, because every question that gets added will lose interest from the physicians who are doing it. So we had to carefully make sure that we absolutely need this information. And so we decided to kind of address the question about tertiary and ambulatory surgery centers or smaller centers by just asking them, what's your shear volume at baseline? So that is it. And that would also help us kind of, say what the drop was from baseline and kind of, break it out as well. So that's essentially what we've done.
Thanks for that. One thing I'm curious about, a running theme in previous weeks has been the idea of representativeness, right? Are you representing the populations accurately in who you're sampling? In this case, is there a good understanding of what the existing endoscopy units are around the world? Was there something you could compare against to say, yeah, we've got about the right share of different kinds of units in North America and South America and Africa and Asia and elsewhere? Does that tool exist? And how did you do some of that, either gut checking or statistical checking of how close you were to capturing the breadth and representative range?
I think for us, you're right. That's an important question. We didn't specifically gear it to kind of having absolute accuracy in terms of having the right number of strata in terms of endoscopy volume based on geographic location, as well as the volumes itself. So our goal was to get as many units participate in this as possible. And the way we made sure that there was some kind of a global representation, and as you can imagine, for these kind of global surveys, not everybody would respond, right? So for these kind of, when we looked at the data, all we were looking was, okay, we know that few continents are not as impacted from a baseline at that point. When we rolled out the survey, there were some continents, US and certain parts of Europe. These were like hot spots, right, at that time. So we made sure there was adequate representation from that hotspot based on the background prevalence of COVID-19 at that time. Now, a few countries like Oceania, the continents, and Africa, probably didn't have a lot of prevalence of COVID at that time. So we were okay if we didn't have too much representation from those countries, but also did not want to lose the opportunity to capture how they were doing and what their guidance has been, because a lot of the type of survey that we have done also depends on the local guidance from their public health departments and their gastroenterology societies telling them, hey, maybe our prevalence of COVID is too low. Why should we stop everything when we're doing okay, right? So they continue to do the procedures that are normally done if there is a pandemic going on. But in the United States, our guidance was different, as Europe or the European Society of Gastrointestinal Endoscopy, where we said, hey, if the prevalence is above this, that's background prevalence, you need to kind of cut back on elective procedures because we need those beds for something else. So a lot of this is depends on the geography, the local politics, the prevalence of the disease, as well as how the local physicians perceive the risk of COVID-19 for themselves and their patients.
Yeah, that brings me to another thing I want to ask about. In the first half of 2020, conditions changed very rapidly. And this is something that affected lots of surveys where I don't know about for others, but for me, some of the days in March, for instance, felt like they were a year long and things were just changing really quickly. And so for some of your endoscopy centers, I imagine it made quite a bit of difference whether they responded on April 24th or on May 11th, because the local conditions or the rules might have changed a lot there. Were you able to drill down at all into how time affected the answers? Or what further would you want to do if you had the resources to dig into that a bit more?
Right. So I think in the United States, if I can remember clearly, it was March 12th that we shut down our endoscopy. We were like, okay, we're just doing emergency procedures, and that kind of came the guidance very quickly, and the national societies and the international societies provided guidance as well. In terms of the timeline, it's kind of hard to capture every day, so that's why we chose the initial time period. And we actually did do a follow-up survey. It's still, the manuscript is under review, but we did do a follow-up survey in December through the same organization, but different set of questions. These were more focused on, okay, now that, in a few countries, we think that the first wave is over. Maybe there are second waves, third waves, and the fourth waves in some countries. But how did you think so one of the concepts was that there might be an extra backlog of these sick patients that we have to take care of. How did you respond? One, are you seeing that backlog? And two, how are you responding to it? And three, is your PPE still the same? Four, is there any role for pre-testing and things like that? So we did do a follow-up survey, and the same methodology. It just goes through the WEO, which is our central platform, and we expected different centers to participate.
Thanks so much for that. I know in the chat, Bryn has mentioned that he has a few questions, so I think this might be an opportune moment to invite you to jump on in there, Bryn.
Okay, I am unmuted. Thank you so much. I might not get this right. Sravanthi. Correct.
Okay.
Not bad for an English colonial bastard, Anyway, I got a whole bunch of questions.
Sure.
In this type of survey, we have a major issue in terms of selection bias. And I'm not sure what, if anything, you try to do with respect to that, because it's also aggravated if I understood what you said, by the fact that you have one, if you like, one response for the hospitals or hospital in one region. You don't have, there's not individual, physicians' responses. It's a response on the part of, maybe I got that wrong from what you said. But if that is the case, this is more generally, the problem of some selected person speaking on behalf of an organization, which itself could be highly, variegated. And so you've got that person's response on behalf of an organization, which is not necessarily, I don't know how to put it, but it's different from an individual response, put it that way.
So, Bryn, let me I agree. So it wasn't an individual physician that we kind of surveyed, but the goal of our survey was to kind of objectively evaluate the volumes, and the people who, the person who was responsible for filling out the survey is the medical director who knows what's going on in that endoscopy unit. So it's basically not their perspective or their attitude to what was going on, but rather what was happening in their endoscopy unit.
Yeah.
Now, the second part that you said was, okay, you did that in different regions. There might not be representation of all the regions, but to be honest, it is either you get any insight into what's going on in whatever way you can, versus not getting any insight. So it is kind of balancing, getting that information versus not getting it at all and not knowing what's going on there.
I mean, I agree entirely, but if I think back to your slide, which was a map of the world, and I look at that slide and I say, my God, look how many dots there are on the Indian subcontinent.
Right.
Compared to the rest of the world. And this was at a time when, if I've understood it properly, the Indian subcontinent was not a particular hotspot in the world. So what have you got here? Sort of advanced elective surgery decisions made by people in your profession in India?
So the point about, I do agree there were more participants, but you have to understand there's more population as well. And even though what you're seeing right now, India is battered right now in terms of COVID, and obviously this wave that they have is nothing compared to what they have in the first wave. There was an anticipation from a political end as well to kind of not go into the wave that you are expecting right now. So what we gather from that information and their participation is, even though they did not have the intensity of the infection that we are seeing right now at that point, they did shut down their elective procedures because that's the guidance that was provided. So what it indirectly also tells us is different parts of the world have responded in different ways to how things were happening elsewhere in the world as well. And these are, people trying to predict, okay, this is what can happen in your country. So even though it seems like nothing's happening right now, you probably have to be careful. And that's what was happening, I think, globally. And that's what I would say of India at that time.
Yeah, I agree with you, but and not knowing India that well, I would have to say that in general, for the COVID-19 business, when we get these alerts, and we get these lockdowns, and we get this and we get that, and so on part of governments now, this is not simply a medical issue. This is a socio-political issue above all else.
That comment there reminds me of some of the work being done. I know some UK institutions in particular doing this, trying to create data sets of some of the policy responses and sort of normative societal responses to be able to try to link those up with the survey data around how policy responses affected public opinion and vice versa. And I think it's a hugely interesting and challenging issue for us, methodologically speaking, to deal with this variegated kind of landscape where rules were changing regularly and where social norms were changing regularly and where disease burden was changing regularly. There's a lot of interesting methodological stuff that we need to do to get at that I hope, as things calm down a little bit in the crisis, hopefully we'll have some time to dig into that. I mean, Bryn, I don't know if you had any other questions there.
No, I did, but I'm going to give the floor to Daniela. Just one thing as a follow-up from that, and that is that the political economy of epidemics is extremely important. And it may be, in fact, and it's a terrible thing to say because people are dying all the time, right? It's a terrible thing to say that the political economy of epidemics is more important than the people dying, which is not the case. The people dying is the most important thing.
Yeah, the political layers are huge and interesting. Thanks so much, Bryn. Daniela, we'll come to you in just a minute here, but I did want to bring out a point that you raised in your presentation and came out in this Q&A, because I know lots of students see these videos in the context of classes and qualitative methods, but I think this issue that Bryn raised around who the respondent is and the point that you made about targeting specifically medical directors is so critical to identify, because one source of potential data contamination in these kinds of surveys can be when you either have multiple respondents from one issue and can't carefully clean between them, or when you have cases of perhaps responses coming from people who don't have the holistic or authoritative picture at a given organization. And this is an issue that I've run into in my research before, working with emergency management agencies. So I'm curious if you had any strategies. How did you make sure this got into the right hands and consistent hands all across the world, where there are maybe different terms used for medical directors or different propensities of those folks to agree to do surveys? How did you make sure that you were consistent in getting the right people to answer this questionnaire?
So it all is on our listserv that we have through the WEO. So we, as the physicians doing the survey, do not have access to that information. And that's part of, the whole de-identification process, which is very important in our medical studies as well. So all we do is say that this is the survey and this is the targeted or intended audience who has to fill this. And then it goes through the secretariat of the large organization, the World Endoscopy Organization, that identifies the right people who will be doing that. And of course, duplicates and stuff like that are taken care of through them. Yeah, so they are like the intermediate body between us and the survey fillers. We have no idea other than what information is provided from the survey questionnaire. We have no idea who that person is, and there's no way to identify the medical director of that surgery center or a hospital that is giving us this information. That's just part of how the de-identification process works.
Yeah, but you've got to admit, Sravanthi, that is a major methodological issue.
Yeah, it's a huge challenge for sure, and one that I've run into a lot in some of my work too. I mean, another feature here, I think, of the community you're surveying is that many of these folks were under an incredible amount of pressure at the time of the survey. And so Bryn mentioned this idea of selection bias, and I think you hinted at a really salient factor here, which is that physicians are a notoriously difficult group to survey. They have a million requests of them at any time. They always have very high pressure task lists that they're dealing with. And so a potential source of respondent bias here could be in the facilities that were, say, the most hard hit by COVID, potentially not having the capacity to respond to the to the surveys or similar. Did you see any evidence of particular medical units or centers being unable to respond because of these time pressures, or was that fairly balanced across those who opted in versus those who did not?
I think if you look at the map, we did have a bunch of, survey respondents from the US and Europe, which were majorly impacted at that time. So if you had seen no spots on Europe or US at that time, then I would say, hey, you did a really bad job, because you're basically capturing low acuity centers. But keeping that in mind, again, the goal of the survey was not per se to make sure everybody out there is giving us the information, but also just to capture on the surface what is it that we are seeing, so that we can provide further guidance as things open up back up to these endoscopy units as to how they can get back to normal or near normal.
Yeah, absolutely. This is a challenge we run into in emergency management research all the time, where the best laid plans of survey design can be challenged by the real world conditions.
So I'm actually, at that point,
I'm
actually curious how, of course, we are not like a expert group running surveys all the time. The goal of this survey was to kind of understand what was going on globally, a very simple goal for us here. But I'm curious, pardon me, probably this was discussed before in previous meetings, but how would you have done this differently to kind of get that information out to these endoscopy units or people on the front lines, and get that published like within 2 months from start to end, so that you're giving them actually a feedback rather than going in circles and not going anywhere?
Yeah, difficult question. Yeah.
Yeah, I don't know if anyone on the call wants to weigh in on that. It's a challenge for sure.
No, I mean, the problem is, Sravanthi, that in order to do that, you've got to ask many more questions. I mean, number one, you'd say from a sample design point of view, I'm going to sample all doctors. You're not going to sample medical officers, officers, whatever. You're going to everybody. You're going to do 100% sample, and you get what you get back. But they've got their individuals. Now, those individuals are then talking about their relationship with their organizations. Oh, big question, for which you need to have a lot of other questions. So your simple, if you like, across the surface coverage for this particular survey, I think is extremely good. I think what you've done is extremely good. But as you will know, it is limited.
Yeah, there are a couple of ways that I've seen this challenge resolved in other contexts too. One is to look for places where some of the data sharing can perhaps occur in, I hesitate to use the phrase more objective ways, but in the fire context, for instance, some of this is data that we've been able over time to make more open. And so we can avoid having to survey practitioners and be able to draw the data, number of cases, number of responders, those kinds of parameters directly from the data sources. The nice thing about that too is it lets us deal with another factor that's an emerging challenge in these contexts, which is that different institutions count things differently. In the fire case, how one group counts a fire, one province in Canada counts a fire is different than another. And so when you're able to get into the nitty gritty of those reporting differences, it can allow for some calibration across. I think to go slightly the opposite direction here too, I think there is an approach to carefully soliciting one response from organizations as well, because it may be an appropriate level to go to physicians to ask about their PPE usage. But in terms of total case volumes, I probably want to make sure that that number is coming from someone who has access to the data.
Yeah, absolutely.
And part of the way might be dividing those up into different kinds of questionnaires, and or just the importance of pre-established relationships, right? To make sure that the access pathways to those medical directors are there. But like Bryn, I think you've done a really bang up job and collected some interesting data here. You did ask a question that I think brings us to a good one from Daniela. She wrote this question a little while ago, but it basically throws the same question back at you. Her question here is, if you were to run the same study again, what would you do differently in terms of survey design or delivery? What were some of the key challenges that you dealt with in the process of running this that you learned from and would advise others to do differently, or wish you could go back and tell yourself a year ago?
I think at the end, this is what we think is getting things done, in the sense, if for us, we really need to get an insight into what's going on, depending on whatever question it is, and knowing that the participation on an average in any kind of surveys, and especially among physicians, is less than 10%. Let's say you send it out to 1,000 people, it would be great if I have 100 surveys back, right? So usually way less than that. So, and then adding on top of it the complexity of, taking care of patients, your time constraints, and, what's going on in the background. It's, I honestly think I would, if I have to get the results back, I would probably do it the same, but probably would also address the question about duplication. As you suggested, try to kind of make sure, again, this is not within our expertise, and that is usually done at the secretariat level. But in terms of delivery, this is a big organization that has access to medical directors or endoscopy units. Yes, it is still a bias sample. It's maybe if the organization is not signed up for this kind of platform or this organization, then they are never going to be in the sample. Now, what's the other alternative? Where do I find the listserv of all the endoscopy units in the world, and how can I get it in a matter of few days or even months? That's not going to happen, right? So knowing what the constraints are and knowing what we want to know, maybe there might be a few different things, but not a whole lot of different things that we might be doing. Maybe, and then also we have to make sure the brevity of the survey is also met with, and then people don't get fatigued because you're sending them surveys every 2 months trying to assess what you want. So you need to know exactly what is it that you want to address from the next survey, and that's what we've done. From the next survey, we wanted to know how people are recovering in terms of prevention of colon cancer, because if your volumes are down, you know that these patients are not coming. That's what we call the collateral damage of COVID on the healthcare. We are seeing increased numbers of colon cancer. That point is what we want to address. And the second thing is, to achieve that, do you have enough PPE? Do you have all the things that you did not have on the first round available now? And the third thing is, from the patient perspective, do you think there would be more responding or to come back to services to seek care other than COVID if they get a test before they do any procedure? Or are you doing a pre-test? And what are their vaccination goals? So this is the more important thing that we wanted to capture. And we've done it probably the same way, because we did get some response the first time.
And I'll mention the technical term here just for the sake of some of the viewers watching and going through training in this. But part of the challenge is not having survey frames in advance of a crisis. The survey frame being the list of all members of the population that you want to get in contact with. And I've seen a number of cases with this in COVID where there are particular specialist groups or niche populations that we want to reach out, and it's it's just very challenging to get a hold of those people because we don't have a complete enumeration of them. Right now in Canada, we're going through the census, which is a location or a time when we can do a complete enumeration of all members of a population, but that's not how we are able to conduct surveys in general. And so I think it highlights the need for infrastructure development during times between crises to develop the relationships and the sampling frames and all of that. But also some of the challenge that we face in the midst of it all, and some of the trade-offs that we have to make too. I know Bryn has one final question here, and then I have one to wrap it up before we conclude.
I'm terrible.
At the end of this, you need to get my name right.
I am very sorry. I have a very, very general question. And I wouldn't blame you if you said to me afterwards, I haven't the faintest idea how to respond to you. Okay. Here is my question. About 30 years ago, there was a move in Canadian social science to say all of these wonderful surveys that we have of public opinion and so on, attitudes, values, behaviors, everything, public surveys, right? They are interesting, but they don't get back to an ultimate sort of, I'll put it in quotes, ultimate cause. And the ultimate cause is not really an ultimate cause, but what it is the extent to which opinions in the public are led by opinion makers who are members of the elite in terms of their pronouncements in newspapers and media and so on and so forth, or of their politicians and so on. So it's the opinion leaders that we thought would be the ones to ask questions of. And we tried, as in your case, to ask questions of the opinion leaders in a survey type of operation. And what we found was that what we were getting was simply what they said in the media. I mean, there was nothing new. So what we decided to do was to change our strategy, and we went for in-depth, qualitative, person-to-person interviews, which could last for an hour, 2 hours, whatever. And we take the transcripts of those interviews, and by golly, then we could really make some sense of what was actually happening. So my question, I'm sorry, going on. My question is basically, what you get from a survey is what you get from a survey. What you get from understanding, in your case, the approaches and mindsets and beliefs and behaviors of your physicians would not be obtained through a survey. That's my question. Now, my question is, would it be obtained through a survey? Let's put it that way.
So I think I got to be clear here. Our survey is not looking at behaviors of individual physicians or their medical directors, right? The reason we approach the medical directors is because they do have access to data that can give us a concrete opinion about what was going on. These are all objective data and not anything specific to what they think. Oh, if I had the question, do you think you need to use PPE for this? Then yes, I get it. The question has to be targeted to all the people involved in care of a patient, not just the medical director, right? That's total bias. But in our survey, it was more to capture what are the volumes of endoscopy that you have seen reduction in, and did you think what percentage of your endoscopy unit was using a PPE versus not? So these kind of questions, unfortunately, have to be directed to the medical directors, because even if you individually sample individual physician, it would lead to more bias than through a medical director. But I get your point. To assess for behavioral changes or in some cases, patient perspectives, like simple things like vaccinations, or do you want to go back and get your colon cancer screening? That can't be just, oh, let me get your community leader and get their opinion on it, right? That is not the goal of our survey. So I think this should be okay for these kind of surveys.
Well, and I think what this illustrates is research well done that evokes all of these other questions, because as you described this project, I mean, I was struck by, oh man, I want to go and do ethnography now in an endoscopy unit of understanding some of the decision-making around how PPE was rationed or what choices were made. I want to do long-form interviews with the patients making decisions about whether or not to delay elective procedures and just what elective means to an individual. And so I think this research has done such a nice job of opening up these questions and capturing that snapshot in the moment. And that was just mentioned in the chat here too, that this is an incredibly complex question with no straightforward way to elicit the information. And so capturing this and documenting it in real time is so critical. Look, we're at the end of our time. Can I ask for a 10-second reply to a final question, which is what's next from here? Do you plan to go back and ask this again and be able to compare as this progresses and evolves? I mean, we're keen to see the December study as well, but what is ahead in this project?
So that's what we call the JICE-2 study. As I said, it was just a follow-up on the first once because of the time that has changed. But ideally, I mean, I am with all of you, is the bigger piece that we find hard from a physician standpoint is getting the patient perspective into this. Like, what is it that the patient wants, right? Do they want to come back? Do they have the awareness that they have to get their screening on time? Do they know that it can cause, we are detecting cancers more advanced? What is it that they would like us to know that could change the practice that we are doing right now? And then that is a question, because it's now sampling all patients who probably have some kind of an underlying gastrointestinal disorder. Trying to tap to those patients is going to be a tough sell, because you need to have the preset criteria, make sure their demographics fall in place, and doing it at a global scale almost feels impossible. So ideally, if I was able to do that, I would do that.
I wouldn't even try to do it at a global scale. I just concentrate on North America. Why not?
Dr. Parasa, thank you so much for your time. This has been a spirited discussion. And as someone noted in the chat too, there's been lots of tough questions, but I think that speaks to the importance of your work and just how fascinating this research is. And so I'm so grateful for your taking the time to be here, to share with us and to be part of this conversation series around survey research. So thanks for joining our community. I lied last week and we did have this session coming up, but we do have a break coming up next week. Stay tuned to the mailing list for the schedule ahead of upcoming speakers. And in the meantime, stay safe and be well wherever you are around the world. Thanks for joining us, and we'll see you again soon.
Thank you very much. Very, very nice. Very nice.
Thank you. Thank you.